Dr. Monika Bhandari, and I'm an additional professor in King George Medical University in Department of Cardiology. Today, I'm going to give you some updates on hypertension, that is rise in blood pressure. According to the World Health Organization, approximately 63% of total deaths in India are due to the non-communicable disease, that is the non-infective diseases. And out of these, 27% of the deaths are attributed to the cardiovascular diseases. And 45% of these patients are in the age group of 40 to 69 years age group. And to your surprise, that increased blood pressure is the most important risk factor for the cardiovascular diseases. And coming to what is the prevalence of hypertension in Indian population, is that over 30 years age group of patient, the prevalence of hypertension has increased in both men and women, and it has increased from 32% to 38% in men, and from 32% in female. So there is a tremendous rise in the increased blood pressure prevalence in the both men and women, and approximately 50% of these patients who are having hypertension are not aware of their diseases, and they do not get treatment. And according to the World Health Organization report, which was published in Lancet in 2021, one in 4 women and 1 in 5 men do not take antihypertensive medication when they are hypertensive. According to the International Society of Hypertension, there should be an optimal standardized care of patients with hypertension, and that should be evidence-based. What does it mean? It means that when there are evidences that particular treatment or particular intervention will lead to decrease in the blood pressure and vis-a-vis decrease in the risk and the event rate from hypertension, should be given to the patients with raised blood pressure. Similarly, the American Heart Association or the American College of Cardiology, which are the standard society for the cardiovascular diseases, in 2021 stated that the patients who are having stage 1 hypertension, that is the patients whose blood pressure, which is divided as systolic blood pressure and diastolic blood pressure, the patients with systolic blood pressure of 130 to 139 and diastolic blood pressure to 80 to 89, that is the stage 1 hypertension, who are having low risk for the atherosclerotic cardiovascular diseases or the 10-year risk, ASCVD, that is atherosclerotic cardiovascular disease, 10-year risk is less than 10%, should begin with the non-pharmacological treatment for the hypertension, that is the lifestyle modification, including daily exercises for 30 minutes or 150 minutes per week, which includes brisk walking and aerobic exercises, salt reduction in diet, intake of the high fruit, that is potassium rich diets like fruits and green vegetables, and low fat diets. So this first treatment should start with this. And if the patient's blood pressure is not controlled within 3 to 6 months, these patients should go for pharmacological treatment, which can be a single drug therapy or in the form of combination therapy. Now, what type of drug to be given in hypertension patient for achieving optimal blood pressure control? This depends upon the type of the patients actually. So recently we have seen the COVID outbreak around whole world, and India is not left behind in this. The Indian population also suffered from this pandemic, and it is still continuing. And acute respiratory distress, the involvement of the lungs is the most important organ involved in the COVID. And if these patients are hypertensive previously, or they develop hypertension during the course of the illness, the type of the antihypertensive medication is important. In such patients, the beta blockers, especially the metoprolol, should be avoided, and other antihypertensive agents like ACE inhibitors or ARB, which acts on the renin-angiotensin system, and the other type of beta blockers like the non-selective one, the bisoprolol, which has less effect on the lungs, should be used. Now, what should be the optimal blood pressure target? The optimal, I said that in the stage first, what should be the starting therapy? I already discussed that in stage 1 hypertension, we should start with the non-pharmacological therapy first, and then give the pharmacological therapy if blood pressure is not controlled within 3 to 6 months, and we can start with the monotherapy in these patients. But if the patient is in the stage 2 or hypertension or more, that is the systolic blood pressure is more than 150 or 160 and diastolic is more than 90, we should straight away start with the pharmacological therapy, and that too with the combination of therapy. The single drug therapy does not control the blood pressure. We should always start with the combination therapy, which controls the blood pressure well, and it increases the adherence and compliance to the therapy also. So the another thing is that what should be the optimal target? Initially, the initial guidelines, they said that the blood pressure can be controlled up to 130 mmHg of the systolic and less than 90 of diastolic blood pressure. But with the results of the STEP trial and the SPRINT trial, which was a trial of the 8,500 patients in 60 to 80 years of age group, they said that a strict blood pressure control, that is the lowering the systolic blood pressure below 120 mmHg, leads to 26% reduction in the composite of cardiovascular events. So this trial supported more strict blood pressure control rather than the lenient. So the patient who are young, that is are below 60 years of age or below 7, should go for the strict blood pressure control, while the patient who are elderly or very elderly, like 70 or 75 years of age, we can go for the less strict blood pressure control, that is up to 130 to 150 mmHg. Now, the blood pressure measurement can be done at the doctor's clinic, or it can be done at home also by the patient himself. It is said that the not only the office blood pressure recording, but the ambulatory blood pressure monitoring or the home blood pressure monitoring is also important. And in fact, the home blood pressure out of office BP, that is the ambulatory blood pressure monitoring, and the home blood pressure monitoring is more associated for giving the risk estimation of the patient for the cardiovascular risk estimation, and it more predicts greater risk of mortality and a composite of cardiovascular events. And it is said that every 20 systolic and 10 diastolic mmHg increase of blood pressure at night leads to increase in mortality, that is the death rate, by 23%, and risk of the cardiovascular events like stroke, heart failure, or heart attack by 36%. So out of office VP is quite an important measure for the blood pressure monitoring. Now, what should be, I have already told the optimal blood pressure control by a combination of the therapy, and the recent guidelines also recommend that we should start with the combination of the blood pressure treatment, fixed dose combination, which increases the like ACE inhibitor and ARB with a calcium channel blocker or diuretic in the first stage, and blood pressure is not controlled within 3 to 6 months, we can add another antihypertensive in the form of aldactone or other class of antihypertensive to achieve blood pressure as early as possible to reduce the target organ damage. And this combination of therapy increases the compliance of the therapy and adherence to the therapy, resulting in the better blood pressure control and better reduction in the risk profile of the patient. Now, what time of blood pressure medication at what time should be taken, in the morning or in the evening? Initially, most of the pharmacological therapy was given in the morning time, because of the increased adrenaline surge in the morning. But it has come out from the Hygia study that nighttime therapy is also an important thing in reducing the cardiovascular events and cardiovascular risk. They compared the nighttime therapy with the usual awakening hypertensive therapy on the risk profile or cardiovascular risk reduction in the patients. This was a large study of 19,000 patients, and the patients were followed up to 6.3 years. They found that the patient who had the nighttime treatment have risk reduction, relative risk reduction of cardiovascular event by relatively greater risk reduction of the cardiovascular events. So the nighttime reduction of blood pressure is also important in reducing the cardiovascular events. So if a patient is we can provide medications in the morning as well as in the night, so that the night pressure is controlled, which helps in reducing the cardiovascular events. So to summarize, it is first of all, it is very important to monitor the blood pressure at home, ambulatory 24-hour, and night blood pressure is also very important in predicting the risk of cardiovascular events. To start with, we should go for the non-pharmacological therapy in the stage 1 hypertension, and if not controlled, we can go for pharmacological therapy. And in stage 2 hypertension and beyond, we should start with the pharmacological therapy with 2 drugs, fixed dose combination. If not controlled, we should add the 3rd drug. And nighttime blood pressure should also be controlled. We should give the patient who have those who are the non-dippers, that is usually the blood pressure reduces in the night, but if the patients are non-dipper, we should give the blood pressure medication at night. And apart from the antihypertensive medication, the non-pharmacological therapy or the intervention in the form of lifestyle modification with daily exercises, salt reduction, and high green vegetable and fruit rich diets is also important. Thank you.